Welcome back to the Breakthrough Medicine Conference. I am your host, Dr. Lori Bouchard. Joining me right now is Dr. Zachary, who has a wealth of information to share. She actually is an author, a researcher, a speaker, and she helps other entrepreneurs help with their own consulting with their own practices. So I'm curious, Dr. Brandy or Dr. Zachary, how did you even get into this field of helping with more of the complex conditions and the mystery illnesses that you'll be speaking about today?
Well, my license is as a chiropractor, and I had a couple different chiropractic practices. And then I had a car accident, so I was in a completely different field. And I actually had many, many clients, most of them in health and wellness, but some in other fields, attorneys, real estate agents, anyone who had to get their own client. And I helped them build their business, do branding, ethical sales, marketing, these types of things. And then I got terribly sick with a mystery illness, one that completely, knocked me off my feet. And I was in bed 22 hours a day. I was declared permanently disabled. I was living in the hospital every 3 weeks, and my treatment cost almost $1 million a year. And that was supposed to be my life. And I was in my late 30s, early 40s when that happened with a little one. So it wasn't ideal. And I sort of just went through the medical gamut and wasn't finding the resources I needed. And that's how I found functional medicine. So it was personal. And as I started to get well, and I really had to be my own advocate, I reactivated my own license so I could do my own research, order my own labs. And I worked with practitioners all around the world. So there's a lot of work. I jokingly said that I read the internet. I was done. I went all the way through PubMed, and when people saw me start to get well, they started showing up at my house. So then I thought, well, maybe I should get a little office, and I did, and then it exploded. I had to move twice in the same year, from 4 walls to 22 walls, adding practitioners, and we've just grown since then. And then I just kept adding to my knowledge base. And those complex cases, if you help one, then they talk to others. And that's how they start showing up. So it very much started with myself and then spread to others.
Wow, not only financially stressed, but emotionally, physically, all of the realms. And you've been in that position of reaching out to everyone and not finding the answers. So you researching and spreading the word on how the body is amazing and healing. I'm just really excited to hear your presentation today. So why don't you go ahead and take the floor?
Okay, thank you so much. And thank you for having me here. I love what you've put together with everyone. What a wonderful service. All right, so let me just share my screen. All right, so you should be able to see the title slide. So this is Fibromyalgia, the Psychosomatic Patient and Medical Mysteries. Fibromyalgia used to be, seen as something that was more psychosomatic. Now we know it's a legitimate condition with physiological reasons. So we're going to talk about that. But I also want to bring in psychosomatic patients as a whole and other medical mysteries. I'm sure you get many of those patients in your office, or maybe you've been one of those patients, and it can be, quite discouraging to have that experience. So those of us that can help them and be a resource is a wonderful public service. All right, little disclaimer slide. This is, educational. Make sure you always do your own research and use your clinical wisdom. Here's the exact order of topics for today. So I just wanted you to know we've got quite a ride to go through. And I will get through it, but I just wanted you to see what was coming and sort of how I'm weaving through and what I'm leading up to. Dr. Bouchard already asked me some questions, so I feel like you already know a bit more about me. If there's any questions later, you're welcome to reach out. I shared my history already of how I got into it. Currently, I teach through Functional Medicine Academy. Body Love Cafe is our clinic, our health clinic, where we have practitioners see patients, and I'm the clinical director there. So I oversee all of the care and labs, and unlike a lot of clinics, we have ongoing teaching and training. So every week, 2, 3, or more times a week, we have training for our practitioners. It's just part of our culture. So I love that. I'm an IFM certified practitioner. They offer a wonderful program. So that's just a little bit about me. Okay, let's dive in. So we're going to start with the history of female patients and why am I focusing on women? Well, there's a lot of different reasons, as you can see on this slide, but the key thing that I want to point out that's relevant to this topic is that about 80% of pain studies are conducted on male mice or men, even though 70% of the people dealing with chronic pain are women. And that's very relevant to what we're going to talk about with fibromyalgia and some of these medical mysteries. The other thing I want to really point out is that IL-6 and 8, interleukin, they've been associated through our research with higher pain ratings. And so understanding what that means, women, we know from research, are physically less able to inhibit those pain signals. So this is not something where it's in their heads or they're not strong. All you have to do is watch one of those videos like a birth stimulator or a menses cramping stimulator, and you can see how strong women are compared to their spouses, right? It can be quite humorous. However, in this example, women are less able, physically less able to inhibit those pain signals. So letting your patients know this is not in their head. They are experiencing pain in a different way. I wanted to give you a few references just for some of the stats on those previous slides. And if I go through something too quickly, hopefully you'll be able to get that recording later through Dr. Bouchard and really be able to take your time, because I know I put a lot of information on each slide. I wanted to give you just a little visual about autoimmune diseases and the incidence by sex. Maybe this is something you've seen before. This came from the journal Emerging Infectious Diseases. As you can see, certainly a higher proportion of women, sometimes as much as 400% more. So there's a little graphical representation. All right, let's talk about how they show up in your office and where do you begin. So this is how the patient shows up, right? Some patients, they show up with a simple tummy ache or they have a headache. Very easy, right? And you're able to often get results right away. But then you have those patients who come in and they have this cluster of symptoms and you're trying to figure out where did they connect? What is this common thread? And there's so many different things. And this is often why in maybe their PCP's office or their GP's office, they might get labeled as psychosomatic because it's such a long list. It doesn't fit a traditional profile, but it doesn't mean that they're crazy. It doesn't mean that it's psychosomatic. So let's keep going here. So what does the practitioner start thinking when they see that long list? They think there's a disjointed cluster of symptoms. There may be visceral pain that's not well localized. Quickly, hypersensitivity and possibly leaky gut is identified. The patient might have a history of many diagnoses. It can be up to 20 or more. There may be inflammation at multiple locations. It may be an entire state. You've had those patients where it's just, they're rigid with inflammation. Maybe their skin, there's not even any flexibility on their skin, on their arm or their legs. They're just in such pain, and the inflammation in their body has now become almost like a glue. There's no flexibility or glide in their connective tissue. You might be starting to identify some genetic SNPs, some slow motility, emotional lability. So a lot of these women end up on a lot of psychotropic drugs that might not actually be appropriate for their condition. You might start seeing signs of infection. They may be highly reactive. This might be the allergy patient that went in and reacted to water, right? And the allergist was baffled as what to do because, the patient reacted to the control subject. So where do you begin? Now, here's the patient's perspective. The patient's perspective is they feel broken, right? They're the one experiencing all of these symptoms. They've gone to multiple doctors and haven't really got an answer. Some have told them that there's nothing wrong with them. Some have told them that they're crazy, or if they just smiled, they'd feel a lot better. And they need to know from you that they're not crazy. That's very important. You need to validate what they are experiencing. In my clinic, we have a philosophy we operate from, and that is one that we believe the patient. They're in their body. If they say they're experiencing something, we believe them, and that's our starting point that we jump off from. Okay, let's talk a little bit about when someone has multiple dysfunctions. What is it that powers the body? So the mitochondria, as you know, when we talk about it with patients, we often say it's the powerhouse of the cell, or it's the body's battery. Some cells have one mitochondria, some have thousands. Liver cells can have 2,000 mitochondria in each hepatocyte. We need them to survive, and depending on the demand of the body, there's going to be a demand for more mitochondria for that organ. So very important. Lots of key functions that are happening at the mitochondrial level. Here's a slide I wanted to show you. So this is healthy mitochondrial function. This is specifically in neurons, because when we're talking about fibromyalgia, that interplay between the central nervous system signaling and the muscular response and the pain signal back to the brain is essential. So we'll dive into that a bit. But here you can see some of the things that feed into the mitochondria and a healthy cell, right? You can see that on the left. ATP, energy, is produced, and then you have a good neuronal endurance. You have a normal resting membrane potential. That nerve is not going to unduly fire. So that's a healthy example. Here's an unhealthy example. Lots of problems you see on the left in these patients. They have dysglycemia issues. They're highly sensitive to environmental toxins. They might have autoimmunity issues, right? Now we're getting some unhealthy cell action. There's a decrease in ATP. These patients are going to be extremely fatigued. Now we're going to have poor neuronal endurance. Those of you that have more of a neuro practice, you see this all the time. You're using all those neuro tips and tricks in the exam, and maybe that's part of the homework and exercises you give patients. They have poor fatigue, even if they can, and this is also why it's sometimes missed by traditional medicine. Even if they can perform a task once or twice, if you actually repeat it, they will begin to fail. They're not able to sustain it. So sometimes they're not asked to do that. And you can see that the resting membrane potential has been changed. It's actually been lowered. So these nerves are going to fire quicker. That becomes very important when we talk about fibromyalgia and pain. So remember that resting membrane is closer to threshold. That means it's going to take less stimulus to fire. All right. They're not imagining it. They're not oversensitive because of a personality disorder, depression, anxiety, or a lack of strong character. They are literally physiologically more sensitive. One other thing I want to point out is some of the signs and symptoms of this dysfunction. Now, you've seen these patients. Some of these signs and symptoms are what I showed you on that cluster cloud, right? Maybe they're getting ringing in their ears. Maybe they're super sensitive to smells. Maybe they're sensitive to electromagnetic fields, which a lot of people don't understand. Someone else, no problem. Someone else, they get a headache. It bothers them. They start to bring that cell phone close to them and they physically feel sick. They might be sensitive to flashing lights, certain sounds, things like that. Mental fatigue after minor cognitive tasks. Pay attention to that. That's another reason these patients get labeled as psychosomatic, but this is legitimate. This is absolutely physical in nature and not psychological. All right, where is energy used in the body? Well, everywhere, but the brain, the liver, and the muscle just really has a high demand. So between those three, you're getting about 2/3 of the demand. Very high concentration of mitochondria in each of those locations. And what are we talking about with fibromyalgia? A lot of mystery illnesses, right? How much is that muscle-brain connection involved, that signaling? The liver, how much How many functions does the liver have? I'm going to show you a slide on that, but just think of like the HPA axis, all of our hormone function, digestion, detoxification. How does the liver not play at minimum an accessory role in those activities? All right, quick little graphic I wanted to share with you, some medications contributing to mitochondrial toxicity, because a lot of times these patients will also show up on a variety of medications. Sometimes they help with one thing, but then they make other things worse, and they might not be serving their mito health. Another slide I wanted to share is looking at true, mitochondriopathy versus mito dysfunction. So this is another time where traditional medicine and natural medicine, we have to make some distinctions. A lot of times the broken piece of communication might be traditional medicine that is looking at a baby born with a mitochondriopathy that's abundantly clear early on with congenital defects, and then that's the only classification of mitochondrial dysfunction. That is truly a mitochondrial pathology. We're talking about something different. We're talking about dysfunction of an organ, similar to the way a thyroid gland could be in a disease state, or it could be under or overperforming, right? You don't jump from perfect health to disease state overnight, at least not in most cases. You either walk or jog in that direction. And often in natural medicine, we're catching people as they're moving from one state of health toward a disease state. And if we can engage with them before they get there, we have a better chance of moving them back towards health. So I wanted to show you some of the true pathology signs. A lot of these you're not going to see, but the ones I put in bold, those you're going to see more often in these types of patients. So you can see there the fatigue, the hypoglycemia, the underperforming thyroid gland, some of the depression, neuropsych symptoms, migraines, headaches, GI issues, exercise intolerance, massive fatigue. So that's going to be common. All right, let's talk about some conditions related to mitochondrial dysfunction and also the consequences of mito dysfunction and dysregulation. So one thing, this was very interesting research, and it's still evolving. So this was 2017, and new research is coming out. So intestinal barriers and mitochondrial health. And keep in mind, when we talk about intestinal barrier health, really we're looking at barrier health, totally. It's not just GI barrier health. We're looking at the lungs, the brain. We want good, lovely working barriers throughout the whole body. But this article was talking about this bi-directional crosstalk between the gut and mitochondria. And it's really fascinating the way it works. And it goes in both directions, and specifically the mitochondria in the liver. So this was fascinating to the researchers, and I find it fascinating also, but depending on the state of gut health, the microbiome, if there's dysbiosis, that signals and communicates to the mitochondria in the liver and the other way around. Fascinating. Here's a slide that looks at altered mucosal integrity, what the lay term leaky gut, right? So this was in 2020. This was put out by IFM, one of their presentations, and great information, great pulling of resources. You can see on the left many of the things that can feed in and contribute to an altered intestinal permeability. Remember, the gut is supposed to be somewhat leaky, right? That's how we get our nutrients across. But when it gets too leaky, that's like having that picket fence and some of the pickets are knocked down, or they're damaged, or they're a little bit too far apart. Particles that aren't fully digested or broken down or weren't supposed to get across that barrier do. And then how does the body perceive those things now entering into the bloodstream, often as a foreign invader? The immune system begins getting involved. And you can sort of see on the right this progress that happens, that immune activation, and that can lead to systemic disease. So what started at a specific spot in the gut can now impact the body globally. Let's talk a little bit about hypersensitized, because these patients often show up as a hypersensitive patient. And you're going to see a lot of this with patients getting diagnoses of autoimmune issues or other inflammatory conditions. Really heart disease for the most part, particularly coronary artery disease, is an inflammatory condition. And same with dementia and Alzheimer's, even depression for large part is an inflammatory disease. So a lot of the things we're dealing with in life right now has to do with inflammation and the impact it has on this end organ. So very interesting. This specific research article was talking about the link between the immune system and short chain fatty acids and the connection in diabetes, obesity, cardiovascular disease, infections, allergies, asthma, etc. All right, autoimmunity, we're going to keep learning more about it. But right now, what we see is that there's sort of a three-step process. Again, I'm simplifying it here, but there's some predisposing factor, usually some genetic predisposition, and that doesn't guarantee someone's going to have it. Just because they have a genetic predisposition, they're not destined to get an autoimmune condition, but usually that's there. And then there's some type of environmental trigger. That previous slide showed many of the triggers on the left, and sometimes I talk about those endlessly. We see more of these conditions now because we have more environmental triggers than ever before. And then there's this immune system exposure, or what we call leaky gut. So there's a trigger, but then the immune system has to be activated. So almost always there's some form of leaky gut involved. And often what you're seeing is bacteria, specifically gram-negative bacteria. They produce a toxin called LPS, lipopolysaccharides, and they don't make us feel good, but it's part of the defense mechanism for that bacteria. And when they get into your bloodstream, there's always a little bit, right? Because we're exposed to bacteria all the time. But when they start increasing, the damage and stress and inflammation that can cause is quite significant. And we're seeing more and more this heavy burden of lipopolysaccharides in the blood, which you can easily test for, by the way, and the conditions that that's causing. Some of these lipopolysaccharides, Citrobacter, what's another one? Klebsiella, some of these, they are known to initiate and sustain the autoimmune process. So besides just bacteria in general, there's specific strains, Proteus, Prevotella, Fusobacterium. There's specific strains that we know, we've done additional research, and they are a lot of the drivers behind autoimmune conditions. So something to be well versed in there. Okay, here's some autoimmune disease manifestations and labels. And I say they're a label. Labels can be very helpful because sometimes they're how one practitioner or one patient talks to another, but a label is just a label, right? It's not an end all be all. Any label, even let's take Hashimoto's, any label really references a process. What is that process that got the patient to earning that label? And are we at a point where we can step back and pull back some of that process? And at minimum, create a better quality of life. And at maximum, reverse that label. These things are possible. So on this slide, you can see some of the conditions that either are an autoimmune condition or feed into an autoimmune condition. And then in the box on the top, you'll see a lot of the triggers. So very important. Now, some of these you can see why we're getting more autoimmune condition. Stress, certainly more than ever before, right? We know that's going on. Some of the hormonal changes, we're seeing hormones, in the food supply, the water supply, in medications, and meats, in personal care products, places hormones never existed before, more metal exposure, pesticides, heavy pesticide loads we didn't have before. Quite frankly, some of them didn't even exist. So the triggers are certainly more substantial. All right, MTHFR, a key player in methylation, probably something you're very familiar with. It's a SNP. Single nucleotide polymorphism. We're still learning more about those. So a lot of these psychosomatic patients, I loved it. One of my teachers said, you know, today's psychosomatic patient is just going to be a snip down the road that has been more clearly identified. So the science is still evolving, and a lot of when we test for like a full genomic panel and we look at this full array of SNPs, probably 80% or more, we don't know enough about. So that gives you an idea, like the ocean, there's a lot of research still to do to learn what's in there. And then the SNPs that we do have more research about, such as MTHFR, we're able to start applying that knowledge. So a lot of people know about MTHFR, some of the you know, conditions and higher risk issues that can happen, some of the impact it has on B9 and B12 metabolism. But remember, it goes entirely around that cycle, right? We've got the folic acid cycle, we've got methylation, we've got transsulfuration. It's all feeding into making a methyl donor. But when you have a piece that's broken, and you have a problem, you have a low methylator. Well, methylation is this simple biological process that occurs like 1 billion times a second. If you have an interruption with that, this patient's going to have a problem potentially globally in their body. So, and it is a vicious cycle, as you can see I put there. Methylation is needed to make ATP. Methylation requires ATP. So I won't totally geek out on that, but again, something you can test if you like labs. All right, let's talk a little bit about pain and mitochondrial dysfunction. Five of the major areas where mitochondrial function plays a critical role in neuro and inflammatory pain, what you're going to see in fibromyalgia over and over again. So I sort of put a little bit some of the pain descriptors on the right. And on the left, you can see some of the different roles where this can interfere with mitochondrial function. So those 5 different pieces, and the mitochondria is even more dynamic than that. Right now, we're really getting into like chemistry and biochemistry. But this is some essential function that's happening here for mitochondria. And this interruption, again, one of those, you know, bio crosstalk situations where mitochondrial dysfunction and pain, they feed back and forth to one another. All right, let's specifically start looking at mitodysfunction and fibromyalgia. You can see on the left some of the issues. I'm going to talk a little bit more about this when I cover some nutrients you might want to consider and some of the testing, especially the lipid peroxidation. And you can see some of the classic symptoms of fibromyalgia on the right. If you want to look up the research here and some of the mitodysfunctions seen in fibromyalgia. So even the label of fibromyalgia, we have to expand on it and start looking at it differently. Sort of like irritable bowel syndrome, right? Sometimes it's a catch-all and we're learning more and more about it, how it's a true physiological condition and not just a catch-all diagnosis. Here's some of the classic fibromyalgia markers. When patients are getting that diagnosis, they need to have 4 of these, and there's a 18-point pain sensitivity markers to get the diagnosis. Let's talk a little bit about some of the pain and genetics about fibromyalgia and how it connects to mitochondria. So when I showed you that slide about that lowered pain threshold and that lowered neuronal firing, because remember, when we experience pain, it's that signal that feeds back up to the brain, right? That's the actual experience of it. You might feel it in your knee, but it's really how the brain is reading those pain signals from the knee. What the research found, this particular article called the Fibromyalgia Family Study, is that low pain thresholds run in families. So there's a genetic component here, and there's also a mitochondrial dysfunction component here. So there's a risk if you have a first-degree relative that has fibromyalgia, you have an 800% higher risk of having it. And there's also a higher risk of psychiatric disorders. Again, not because you're crazy, not because they lack character or strength, or they just aren't tough enough, or any of that other baloney you hear. but for physiological reasons, for the reason I showed you earlier, the inability to impact IL-6 and 8, some of the pain interleukins, for the increase, when you have that increase in inflammation, if you understand that depression is largely a disease of inflammation in the brain, then you understand that when someone has a different condition, increasing inflammation, and it's becoming systemic, then depression is much more likely. Again, a physiological reason. Okay, let's look at juvenile fibromyalgia. Different condition, yet connected. I put some of the genetic influences, environmental. This graphic is directly from that research article. So you're welcome to pull it up and see it. So it's taken directly from there. Look at some of the biological factors, some of what you're dealing with patients. HPA, don't forget that hypothalamus, pituitary, adrenal axis and that connection. Look at the symptoms. Look at that green cluster in the middle, right? This is what these patients come in. So now you're seeing like tweens and teens, and a lot of practitioners or parents might say, oh, it's just a teen sleeping a lot, or they're grumpy, or they get withdrawn, or they're going through a phase, or they're having cognitive issues. Maybe it's ADHD or, things like that. And if you don't really find out what's underneath it and you miss an example of juvenile fibromyalgia, again, just a label, we want to look even deeper. It's really a disservice actually to that child, because the negative effects, which you can see on the right, are really significant, and it can actually change the direction of a child's life through their entire adulthood. To be living with that kind of pain and not have it taken seriously, and then their behavior, they might reach for recreational drugs because they're trying to self-medicate because no one took their pain seriously or understood it. They might hang with a different crowd that all of a sudden is outside their normal because they couldn't do the same activities their regular crowd was doing. So maybe now sports fell off the table for them, or certain social engagements disappeared because of the pain they felt, or the depression they were experiencing, or the anxiety. And this age, they're not always verbose about communicating. So you have to really dig. So really, have your antennas up for this. And parents aren't going to know this stuff. Okay, this article talked about juvenile fibromyalgia, anxiety, mood disorders, and pain. So young adults with a history of juvenile fibromyalgia, just what I was saying, are going to not only have more likely to have current anxiety or other mood disorders, but a lifetime of it, which honestly can make me cry. It's so tragic to miss those kids. And then they just get set on a path that isn't necessary. So I've worked with these kids. I have these kids in my family too. So I really know what it's like to try to serve them in that way. You can see a little cluster of some of their symptoms to the right. All right, let's talk a little bit about fibromyalgia syndrome. It's a functional disorder. There's classic fibromyalgia on the left and pseudo fibromyalgia, not meaning that it's fake, but just that there can be a different true condition that gets labeled as fibromyalgia. And then you can see some of the organic diseases that show up on the right, some of the functional issues, some of the musculoskeletal issues that will show up. Really your wheelhouse of who comes in your office. I wanted to share a little bit of some things to assess and some nutritional recommendations. We're going to get into this a bit more, but just a little snapshot. So on the left, these are not, the fibromyalgia patient, if you really want to dig into it, it's not a simple patient. It's not just pain management, far from it. So all those issues on the left, you want to weed your way through. And then on the right, that's just sort of the tip of the iceberg for some of the things you might want to work with. All right, I want to start getting a little bit more into pain. You'll see where this is going to evolve. So here's, I wanted to talk about many forms of chronic pain, and you'll see, fibromyalgia is on there, but it's just one of them. So a lot of people might get a fibromyalgia diagnosis, but maybe they have PTSD, or maybe they really have rheumatoid arthritis, or maybe they have IBS. Maybe they have multiple things. That's possible too. They might show up with 5 of these things, in their medical chart. And what that starts doing is start feeding into and creating what we call centralized sensitization, spelled with an S, usually in Europe, a Z in America. But this centralized sensitization is the same thing as that lowered pain threshold I was showing you. What it really means, and you can see it on this next slide, what it really means is that not only are these patients firing pain signals quicker and more often, but they often then start firing them even when the stimulus is removed. So the body learns. That's what becoming sensitized means in that way. The central nervous system, you've heard that expression, the wires that fire together, or the neurons that fire together, wire together. So the body becomes trained, the brain becomes trained for these pain signals, even when the stimulus is gone. That's very problematic. And this research article was bold enough to say that chronic pain should be considered a neurodegenerative disorder in itself, just the pain itself. Okay, let's talk about this now. And start putting a few of these things together. So we've got a patient with multiple symptoms, and they may have conditions, fibromyalgia, PTSD, endometriosis, Hashimoto's. They may have a list of diagnoses that can be related to mitochondrial dysfunction. So now what? So patient shows up, multiple functional issues, but nameless overall condition. Here's some of the diagnoses or symptoms you're going to see, right? And these concepts, each of those concepts, by the way, are widely discussed in existing and emerging research, but there has been no name for this cluster of conditions. So this was something that we pulled together in early, late 2019, early 2020, just thinking about the psychosomatic patient, and that she was due for a name and for an explanation, and that psychosomatic was not accurate when there's physiological causes for her pain and suffering. I thought it was very important that she knows this is not in her head, and I get that she's tired of being ignored. So we call this cluster metabolic immune sensitized syndrome and energy dysregulation, this whole cluster of symptoms, or for short, MIST. So metabolic immune sensitized syndrome and energy dysregulation. We're going to break that out a bit more. And MIST for short, which the acronym seems very appropriate considering this patient is often missed or overlooked in traditional medicine just because she might not fit the mold. All right, let's talk about mitochondrial dysfunction clues from the exam and some of the lab workups for the MIST patient. First of all, there's often a history of ACE, adverse childhood experiences. Probably know about this, but if not, do some reading on that, some good scientific research that shows, and by the way, you can offer this test as a simple paper test. Patients can take it online for free, or you could have it in your clinic, certain questions. The same ones they used in the research study, that the number of adverse childhood experiences leads to more health issues, diagnoses, lifetime pain, disability, social problems, and early death. So very important. I love that they're looking at this, right? Because this is part of what functional medicine, holistic health, naturopathy, right? It's part of what that's all about, is looking at the whole of the patient, their history, their genetics, multi-generational trauma, right? We have great research on that. So we want to consider all of this. So again, that shot of that patient again, what are they coming in with? Those multiple and varying symptoms, hypersensitivity. They could be everywhere on this continuum at one time. History of infections, they're allergenic, they may have autoimmune symptoms. They have that unhealthy membrane potential I showed you very early on. And here's some clues from the physical exam that you can see. One you might see a lot is low blood pressure or extremity skin temperature that's much cooler than their core. I wanted to give you a few other possible patient physical exam findings. There's a lot there, but I highlighted in the gold some of the more common ones. Those fibromyalgia trigger points, of course, but some skin issues, some cognitive balance issues, fissuring, scalloping on the tongue, low blood pressure. Here's some labs. So for those of you that like to do labs, I love labs, love teaching them, love using them. Even traditional labs, very simple, low cost, CBC, CMP, liver function. You're going to see some clues that suggest mitochondrial dysfunction. Oxidative stress. Those of you who maybe do quantitative urine testing and organic acid testing, you'll see it there. I'll give you some specific markers in a minute. Here's a few. I'm going to show you more. You might test amino acids. Here's some of the organic acids you'll see on a urine test. So these are specifics. Here's an example of one marker. This 8-hydroxy marker, you see that more and more now. In fact, it's even on the Dutch. So if you do hormone testing, you'll see that on the Dutch test. I believe it's on page 5. Now, it's not like this marker is an end-all be-all. If someone's normal, it doesn't mean that, oh, it's impossible for them to get cancer. But this is an early marker of oxidative stress, so it can be very helpful to see it. And then I put some other markers there for you, some simple blood markers, lipid peroxides. Sometimes you might get a specialized panel, or the LP play. That stands for lipoprotein associated phospholipase A2. But that's really looking at this enzyme in the endothelium and an early marker for soft, unstable, active growing plaque, which is an increased risk for stroke. MPO stands for myeloperoxidase, another enzyme. And when that's elevated, a little trick they don't talk about that often is you can see that elevated in rheumatoid arthritic patients, sometimes also juvenile fibromyalgia, but most oftenly it's used for heart conditions. And an elevated MPO, often with other markers, like if CRP is elevated, a C-reactive protein, it is a sign of what's called MACE, major adverse cardiac event, and it can predict the increased risk of a heart attack or stroke in the next 1 to 6 months. So again, part of that role, I was talking about coronary artery disease and the role of it as an inflammatory disease. But sometimes you'll see someone where that MPO is elevated, all their heart markers are fine. So then you have to look for other reasons why MPO would be elevated. Also, the 4-hydroxy E1, if you're using the Dutch, that's on page 3 of the Dutch. Remember when you look at the metabolism of estrogen, you see that green pathway, the red pathway, and the blue one. You want to drive down that blue pathway. That's the protective estrogen metabolism. Well, that red one, you want to keep it within a certain percentage, because if that gets higher, you have more oxidative stress and potential DNA damage. So putting these little clues together, especially if you have a patient show up, if your office is like mine, sometimes we have a patient show up and they come in with a binder of labs and they've already seen 10 other functional practitioners besides going through an entire hospital of medical practitioners. So someone might already come in with a lot of labs, but there are these little clues on each one and they haven't yet had a practitioner put it all together. So I'm hoping this will help you with that. I give a few supplements just to help with oxidative stress. There's certainly more that you can do. A few other lab testing signs, getting into some of the environmental toxins, metals and chemicals. When you're evaluating some of the digestive and key nutrients for this MIST patient, these are some of the things that you want to look at, specifically that sympathetic nervous system and neuroexcitation that keeps them in this high stress, high oxidative stress, high pain threshold, right? You know, low firing threshold, but high pain experience. All right, here's some issues to address in the MIST patient. So if you could sort of just really get these on the left, and I'll wrap it up for you at the end too, and just give you a little summary here. But these are some of the things you have to work. These are not overnight things. These are not quick. This is a process. Working with the gut and the brain barrier, stabilizing blood sugar, dealing with mitochondrial health as a whole, structure and function in the body, musculostructural issues, self-care, stress management. This is something Dr. Cara Fitzgerald talks about this, the 6R protocol instead of the 5R. And the 6R is reduce. It's palliative care in the beginning. And that's something that as functional medicine practitioners, we love to like, well, let's get in and go attack that dysbiosis. Sometimes this kind of MIST patient, we need to get them feeling a little bit better. They need palliative care before we do anything like that. Even a gentle dysbiotic protocol can make them feel worse. So don't forget that reduce, that 6R. Okay, wrapping up. I know this one was long. Sorry, folks. We're almost at the end here. I wanted to show you a few therapies and lifestyle activities to support mitochondrial health for the MIST patient, things you can work on with them in your practice. So here's some of the lifestyle changes. Again, not overnight. It's not like a grocery store where you can just give them a list. They all grab it at one time. It's hard to make these changes. So especially if you have health coaches as part of your practice, this is a great way for them to have regular visits and someone to really coach them through this. It takes time. It takes hand holding. So there's some important issues, lifestyle changes. Here's some more specific modalities divided into like electrical, acupuncture, some of the physical medicine. When you see hot and cold therapy listed there, a lot of things that are going to support lymphatic health and lymphatic drainage will be helpful. Some of the mind-body, don't forget mind-body. First of all, we do have some good research for mind-body, but not everything can we quantitatively prove. That doesn't mean it's not beneficial. You'll even see placebo listed there because the impact of placebo can be beneficial, right? Giving people hope and letting them believe that there can be some improvement. If they can embody it, sometimes that's what allows them to move forward and start making some of those physical changes. Heart rate variability, for those of you that use it, can be a good tool to offer the patients to practice at home. Here's another graphic utilizing gate theory and increasing firing to the brain. So one of the ways we can block pain signals is by using some of these multitude of resources we have. For some of these might be right in your wheelhouse or your main thing. So just know how important those skills are that you bring to the table. For those of you where none of these are your wheelhouse, then if you don't have someone in your practice who does this, reach out to others in the community so you have some good referral sources that you trust. I always like to, we have multi-practitioners, so we're pretty covered, but we don't have everything. And what we don't have, I like to test them myself, throw my family at them too, and really make sure that the referral is one that I believe in, have a good experience with, and then absolutely whatever the patient needs, give them that referral. I do want to mention, even though we work almost entirely with natural resources, is LDN, low dose naltrexone. That is a prescription medication in very, very low dose, normally used for opiate addiction in about 50 to 300 milligram dosage, and low dose is usually around 4.5 milligrams, done by a compounding pharmacy. And it's very interesting. It's been used this way by MDs since about 1980. And there's some good research, not as much as we'd like because there's not a lot of money in it, but certainly a lot of clinical experience. And it can be very helpful with this missed patient and in fibromyalgia. It's basically taking this small amount of a medication and using it in a homeopathic way, where the true benefit is what your body does with it. So you basically block opioid receptors for a brief amount of time, and then as a result, the body produces more opiates, more opioid receptors, and receptors that are more sensitive. And then we now know through research that the amount of opiates you produce is directly related to your neuroimmune health, a system that not that long ago, we didn't even know it existed. So now anything you can do to boost neuroimmune health is also going to highly benefit these missed patients and certainly fibromyalgia patients. Okay, foods and supplements to support mitochondrial health. Last few slides here, my friends. Here's some foods. So I just wanted to give you some pictures. The goal is high antioxidant, high vitamin and mineral content, immune boosting, anti-inflammatory, and supporting detoxification. So I don't care what food you use, just try to find foods that are going down that pathway. Here's a few plants and constituents that induce ARE via the Nrf2 pathway. So we're talking about antioxidant response element. And when you're talking about mitochondria, part of the workhorse that is mitochondria is it produces ROS, reactive oxidative species. And the body needs to handle that. Otherwise, we end up with free radicals. So this ARE is part of how we neutralize those oxidative species. And it's part of how we detoxify chemicals. And so you want to promote the Nrf2 pathway. So there's some ingredients. You might have your favorite supplement that contains it. And there's the link so you can do some more research on it for yourself. Now, here's a few nutrients for the missed patient, specifically to support mito health. And I broke it down to some of the functions within mitochondria. So some key carbs, fats, proteins, what supports the citric acid cycle, energy transporters, electron transport chain, acetyl-CoA. So, and you can certainly see that there's some overlap there. So those patients typically, you don't want to give them all those separately. They're going to need a suitcase with their supplements. So you have to find a good blend that you like, that works. Here's some more supplements. Some of these I listed before, but that will help with detoxification. These patients are absolutely going to have detoxification issues. And remember, it might not be wise to begin with that. So you have to see where that patient's at. And sometimes these are like dip the toe in the water patients, very, very slow. Some are so hypersensitized, you have to do one thing or even one supplement at a time. Okay, let's wrap it up here for you. So I recommend getting curious, looking at it from a functional perspective, and be very patient. It's going to take work and it's going to take time. So manage expectations with that patient. Let them know what's involved. Fibromyalgia and other medical mysteries are often labeled as a psychosomatic patient. More often, the truth is it's a cluster of separate and connected issues. Sometimes that can be reduced down to mitochondrial health issues, and that patient deserves a systematic and specific care plan. What we refer to as the missed patient requires, this is where you really want to walk them through this, lifestyle, structural, and nutritional support with a focus on anti-inflammation, right? Addressing pain. That central sensitization is key. That's a big part of the missed patient. And hypersensitivity. Remember that 6R protocol. Resolving key metabolic issues. That's the M in MISS. Specifically blood sugar regulation and HPA issues. Address immune issues. That's the I in MISS. They may have hidden infections. They may have an increased viral load. So we need to look at that. You're going to see a lot of HPV and EBV patients, right? Detoxification is important. Stress management, improving vagal tone. And then remember, again, this doesn't mean it's all in their head. They're having a normal reaction to a physical issue, but they're going to need social and psychological support dealing with relationship issues. They may have a history of trauma. So it may be something you can handle in your office, or it may be something where you need a multi-practitioner team approach, and having some, holistic psychotherapist or counselors or support groups to take them through and give them the support. All right, so next steps, just keep supporting your patients, add new skill sets. Don't be afraid to help these challenging patients. You don't have to know everything at once. You can just start where you start. And as new things come up, you just look up new things, research them more, use wonderful resources like this Breakthrough Medicine conference, and go from there.
Wow, Dr. Zachary, what a fantastic presentation. You just jammed packed so much information in there to help other natural health practitioners utilize all of these tools. And I can see the frustration, and when you almost got emotional at part of the presentation, just seeing other patients who haven't also been missed, or they're walking around with this diagnosis thinking they just have to live that way. And they've seen multiple practitioners spend thousands on lab work and still not really finding any answers. So I'm so grateful that you're able to use all of your research and all the information that you have to help other practitioners as well.
Thank you. It's my pleasure. I love teaching other practitioners. It's my favorite thing. And then they go out and help so many. So it's a way to have a broader reach, right?
Yeah, exactly. I did have one question though. So when the slide that you had about leaky gut and all of the things that can contribute to that, do you do zonulin testing? Like, is there a marker that you test for that? Or do you just kind of like look at the oxidative stress and mitochondrial health and look at the bigger picture there? Like, is that part of the process?
My favorite test, because there's a lot of leaky gut tests out there, my favorite one is called Advanced Intestinal Barrier Assessment. And it has zonulin, which can be helpful, but it's not always the best marker. You can't rely on it at 100%. So it has zonulin and DAO, diamine oxidase, which is the enzyme that breaks down histamine. It has histamine and it has lipopolysaccharides on it. So it's a blood test. So I like seeing all of it together. I consider it much more accurate. And I especially love it if I can see, I like GI map, if I can see a test, a stool test where I'm looking at what's going on inside the gut, what the specific bacteria and overgrowths are. And then I see a blood test so I can see what's getting across and how that patient's body is responding. So that's my personal ideal. I like seeing it that way.
And what's a typical time frame of when you have all those labs and you say, okay, for sure that they have inflammation, leaky gut, like you've seen all the diagnostics, but then when you're implementing this protocol, what should patients expect when you say, do you retest again after 3 to 6 months? Or like, what does that look like?
In our practice, patients come in and they have a very low cost intake with a health coach. And we spend, years training them. And it's gathering all their history together, seeing if there's some like basic lifestyle things, some pain, stress, sleep, nutrition, some things we can begin with right away, maybe some palliative care, and helping to discern what tests they need. But then the next visit is a report of findings with one of the practitioners. And it's at that point, so we're talking anywhere from about 3 to 5 weeks after they first come in, that we have their labs and we're able to give them a full picture and say, here's what's going on. Now, if there's a budget issue and they can't afford all the labs, we just work with what they can get and try to do the best we can with what we have. And then maybe there's a lab they must have and it's later, and we'll bring it in at that time. But if we have maybe only one lab, and someone's able to make a lot of improvement, then great. They don't need to get a lot of other things. So it's really customized for every person. And we retest when the lab markers are very significantly off, and we need to see that they've improved, or if a patient isn't getting the improvement we see. Mm-hmm. But if the lab markers weren't a complete hot mess and that patient's getting a lot better, we don't retest just because of budget issues. And most of the time patients are paying out of pocket. So we're trying to be very sensitive to their economic issues.
Yeah, no, I like that. So it's just really gauging where the person's at, their personal situation, and really what you're looking for. Because I'm sure a lot of it can be assessed just symptomatically too. You don't need to spend 500 on a test to say, okay, your energy is up, and to confirm certain things. But I can see where in certain situations that would be really helpful to do that.
Yes, our intake paperwork is 14 pages long electronically. So, if you have a really good history, you have such a good running start on what's going on with that patient if you really ask the questions.
So how can people get a hold of you, whether it's practitioners or patients looking to get more information from you? What's the best way that they can learn from you and learn more about the MIST protocol?
For patients, our clinic is Body Love Cafe. So you can just go to that website, bodylovecafe.com. And we have a lot of free educational videos. And if you want to, become a patient, you'll see the whole process. And I'm really big on transparency, all costs, everything's just right up front on the website. And then for practitioners, I love training practitioners, not just our own, but I actually take care of practitioners on 5 continents around the world. And that's usually through Functional Medicine Academy. So you can go to thefunctionalmedicineacademy.com. We teach classes there, and I do some private coaching. And it could be clinical, like I advise on patients or advise for them, or I help them set up their virtual practice or create a website, or, patient flow systems. Really, it's marketing, branding, whatever they need.
Yeah, I can tell you're extremely passionate about this, and you're just doing amazing things in this world, helping other practitioners and therefore helping a lot more people. So thank you so much for your time. I'm honored for all the information you've shared and the time that you've spent with us today. Thank you.
Thank you so much.